Medurstand-Understanding Medicine.
I'm Professor Aziz Rehman, and we are going to start a series of lecture on different kidney diseases. I've already covered the basic lab interpretation, but we will be going into more detail in subsequent lectures. And today we're going to talk about this condition called post-streptococcal glomerulonephritis. I think that name says it all. It is something which occurs after streptococcal infection, which is very common. Streptococcal infection is very common, especially in children, particularly in our country. And rare patient would develop this complication called glomerulonephritis. That means there is inflammation of the glomeruli, and that of course results into various kidney problems. I think before we can understand the pathophysiology of this disease, we need to understand the structure of glomerulus. Now this is the schematic diagram. Our kidneys have numerous, like I think approximately 2 million functional units called nephron. And a nephron consists of a glomerulus and then the tubules. And the glomerulus this is the Bowman's capsule, this is the space, and this is the arteriolar tuft. This is the afferent arteriole which brings blood to the glomerulus, and this is the efferent arteriole which takes away the blood after filtration. Now this is a unique vascular system in the body. This is arteriolar portal system because the blood is drained by the arteriole. Normally the blood is drained by the venous system, but this is arteriole. But this arteriole then, which will I show in the next picture, then goes around the tubules and then absorbs many nutrients and other things, and then ultimately urine is formed. So this is very rich structure, and there is capillary tuft, and all these capillaries are lined by endothelium, and on the outer side this is the epithelium of the tubular system. So there is basement membrane. On the inner side there's endothelium, and on the outer side there's epithelium, and this is the space where fluid is filtered first. You know, minus proteins and cells, almost all plasma is filtered into this. Amino acids, glucose, all electrolytes are filtered into this, and then they go on to this tubule system, and most essential nutrients including electrolytes, glucose and amino acids are reabsorbed. But it offers barrier to this glomerular structure, offers barrier to proteins and cell in normal state. If this barrier is broken, as can happen in glomerulonephritis, then lot of protein will leak into the tubules, and also some cells will leak into the tubules, and these cells, they can make different casts in the tubular system, which we can identify in the urine. So this is the most relevant structure and function of the glomerulus. Now this is further on the afferent arteriole. This I showed you, the afferent, and this efferent, this goes around the vessel. This is a very interesting tubular system, the proximal convoluted tubules, and then the distal convoluted tubules, and the loop of Henle, and this goes into the medullary part of the kidney, which has got very concentrated interstitium, and then it comes back. So all the nutrients like glucose and sodium and amino acids, they are reabsorbed, and some waste products like creatinine, urea, uric acid, they are excreted in the urine, and all this is regulated very effectively by various systems. For example, this arteriolar tone is regulated by our RAS system, renin, angiotensin, aldosterone system, also vasopressin, also sympathetic nervous system, also cardiac output. So all these regulate how much blood should go into the glomerulus and how much should come out of that. Now also there is vasopressin, which tells our tubules how much water to be reabsorbed, and normally water is prohibited from being absorbed, but it is vasopressin which allows it to be reabsorbed. So that is why the absence of vasopressin would result in diabetes insipidus. Now one factor which regulates the circulation is tubuloglomerular reflux. Now you know this tubule system, then when it goes back, it passes very close to the nephron, and there are some specialized cells on these tubules called medulla densa. These are some special tubular cells here which actually sense the amount of sodium and water coming to this stage, and from that this system can sense how much more need to be filtered from here, so it regulates the arterial tone. So this is a very interesting mechanism. So this was, I think, the basic concept about anatomy and physiology, and now we will go directly to our topic of glomerulonephritis. Glomerulonephritis is a very broad group of disorders. Now I will of course very briefly touch upon them. There could be primary diseases. That means the primary insult is with the kidneys. So the disease directly affect the kidney. Like minimal change disease, and this is usually a complication of post-streptococcal glomerulonephritis in children, and it is called minimal change disease because you don't see much on light microscopy. Of course there is problem, but on light microscopy the things do not appear to be frankly abnormal. Then IgA nephropathy, focal segmental glomerulosclerosis, which is seen in adults. Membranous nephropathy, again another common condition which causes nephrotic syndrome. Membranoproliferative glomerulonephritis. This can also be complication of post-streptococcal glomerulonephritis. Crescentic glomerulonephritis, again a complication of the same. Then we can have some involvement of kidney in many other diseases. Like any autoimmune disease, particularly systemic lupus erythematosus can affect kidneys. So that is called lupus nephritis. This is usually a part of a systemic disease, but sometimes nephritis may be a predominant component. And diabetic nephropathy, you know, diabetes can cause many complications, and one of them is diabetic nephropathy. Then Henoch-Schönlein-Purpura, which is an IgA vasculitis, that can also occasionally affect kidneys and can cause nephritis. And believe you me, this is not the complete list. There could be many other diseases like amyloidosis which can cause glomerular diseases. So we are now going to focus on our today's topic, that is post-streptococcal glomerulonephritis. So what is the prevalence of this disease? It's a rare complication of a common infection. You know, streptococcal infection is very common, especially in our part of the world, because it is actually related to our overall hygienic situation and the crowding. And when there are children, they live together and they cough and they don't take care of the coughing etiquettes, and they cough on each other's face and they can spread the infection. So streptococcal pharyngitis and some cases streptococcal skin infection called impetigo, they can lead on to post-streptococcal glomerulonephritis. Luckily, most, I think great majority, maybe 99% people with streptococcal infection will recover. Only a rare person will develop glomerulonephritis. Now this is briefly the pathophysiology. Now first of all, there is streptococcal infection. Not every streptococcus can cause this infection. It is the group A, and actually certain strains of group A. I am not going to go into that detail because that may not be clinically relevant, because in clinical settings we cannot actually detect that. So streptococcal group A specific strain, they cause pharyngitis, tonsillitis, or impetigo, which is skin infection. And as a result, antibodies are formed. Like in any infection, there is formation of antibodies, and in majority these antibiotics will clear the infection. Maybe if this patient gets medication with antibiotic, the infection will clear faster. But even if somebody does not get an antibiotic, there is a good chance that antibodies will neutralize these bacteria and will clear the infection. But in some cases, there may be antigen antibody complex formation, and this is filtered. This circulates in the in the body, but in glomeruli it settles down. Why particularly glomeruli? Maybe because of there's some antigenic similarity or just chance, or maybe because there is a lot of blood flow going through the kidney. So that is why these immune complexes, the antigen antibody complexes, they get trapped in the glomeruli. And there it induces very intense inflammation. Immune complexes are formed, and they also involve complement, and then the complement is activated, and this results in a very intense inflammation, which also attract various types of cells like neutrophils and eosinophils and monocytes. All are attracted in the glomeruli, and intense inflammation is induced, which causes damage to the glomerular basement membrane and endothelium and epithelium, resulting in porous and resulting in damage. This damage results in the pouring of proteins and cells into the Bowman's capsule and the tubules. So, and that can result in either nephrotic syndrome. And nephrotic syndrome, we'll have a separate lecture on nephrotic syndrome. Nephrotic syndrome means there's massive proteinuria, more than 3 grams per 24 hours. That results in a specific syndrome called nephrotic syndrome, or it could result in nephritic syndrome. Nephritic syndrome is actually another condition where there could be hypertension and hematuria and rapidly progressive renal failure. So either of the two could then result in further kidney damage. So this could progress to end-stage renal disease and full-fledged nephrotic syndrome, and many would result in then would require renal replacement therapy. Now, the prognosis, the progression from this to this is variable. As I mentioned, only occasional patient will get this glomerulonephritis, and many would have a smoldering course, and some would stay in nephrotic syndrome and nephritic syndrome for years and decades, but other would develop progressive decline in kidney function and would result in renal failure. So clinical presentation, first of all, there is the first thing which usually patient notices is either oliguria or swelling. Oliguria means reduction in urine output. So there is significant reduction in urine output. You know, normally our urine output varies according to the water intake, but these children, they notice that despite normal fluid intake, their urine output is reduced significantly. Sometimes it may completely cease, and that would call anuria. And this would result in retention of water in the whole body, and that would result in the formation of edema, which is particularly seen on the face and the legs, but it could actually be present all over the body. Hematuria is another very important symptom, and hematuria the patient would notice as smoky urine or Coca-Cola color urine or red urine, and there are various colors actually, because some hemolysis would result in free hemoglobin and some intact red cells may be present. So there may be hematuria, frank hematuria, which patient can see. Usually clots are not present, because presence of clot would indicate the hematuria coming from the urinary bladder or the urinary kidney pelvis. Since this one is coming from the glomeruli, it would be uniform hematuria. Then massive proteinuria with or without hematuria. So proteinuria, I think normally, you know, less than 300 milligram, normally actually less than 30 milligram of protein per 24-hour urine is present. But in these patients, anything like 3 gram, 4 gram of protein can be excreted per 24 hours. Then hypertension, especially those patients who develop nephritic syndrome, they would develop hypertension. You all know kidney has got an important role in the regulation of blood pressure, Now in this condition, because there is anuria and there is activation of RAS also, there's a lot of renin activity, and that would result in hypertension, and this hypertension may become malignant, and this could further lead into pulmonary edema and heart failure and other stuff. So now I'm going to show these features. The first of all, this is the facial edema. This could occur in many other conditions, but this is the typical facial edema of post-streptococcal glomerulonephritis. Then pedal edema. This is pitting edema, both sides, and because this is nephrotic syndrome, and if you press your thumb against the bone and you keep it there for a few seconds, you will see this pitting formation, and this indicates the presence of free fluid, in the interstitium. Then we can have hematuria. You can see this is dark color urine and it is uniform. So this is typical of hematuria in post-streptococcal glomerulonephritis. I think diagnosis is easy. If a child develops reduction in urine output and swelling, you should become alert, and this should lead to the diagnosis, and then appropriate investigation will confirm the diagnosis. Urinalysis is extremely important, and if you examine urine with dipstick, you will see presence of proteins and presence of hemoglobin. And when you see the blood, it would look red or dark color, and specific gravity will also be increased. And then when you examine it under the microscope, you will see various types of cells. You would see RBCs, WBCs, and sometimes you may see the cast, granular cast or hyaline cast. So these casts are highly suggestive of glomerulonephritis. So this is the smoky urine, and in urine examination, I have already mentioned this, and blood test, creatinine would progressively increase. Now, if there is complete renal shutdown, creatinine would increase at a rate of approximately 1 milligram every day. Blood urea, nitrogen, and urea would also be increased. So these are classical features of acute renal failure. Potassium is usually also increased because normally kidney is removing potassium from the body, and once there is renal shutdown, especially if there is complete anuria, there is a rapid rise of potassium. This could lead to many complications. Proteins in the blood are reduced, so that could result in nephrotic syndrome. Proteins, especially the albumin, is reduced, because although there is proportionate increased production by the liver, but of course that would take some time. So liver may not be able to produce as much protein as kidneys are losing, so there would be hypoproteinemia, particularly hypoalbuminemia. There may be relative hypergammaglobulinemia. Lipids are also increased because when there is hypoproteinemia, lipoprotein synthesis is increased, so lipids are also abnormal in nephrotic syndrome. This will not, of course, develop in every person. There will be variable abnormalities. So renal biopsy, one would consider that the renal biopsy would be needed in all patients. I think it is not. It would be final confirmatory tests. Mostly it is not done because the diagnosis is usually clear on blood test. I think in blood test we also do this antibody titer. That will also indicate actually the infection. That would not confirm glomerulonephritis. The streptococcal antibodies against streptococcal antigen is tested. If we do renal biopsy, of course, in autopsy studies and in earlier studies when kidney biopsy is done, there are various abnormalities which I'm going to show you here just to complete the module. But as I said, in routine clinical practices, kidney biopsy is not done for just for confirmation of the diagnosis. Now, histopathology on light microscopy, there may not be much. There would be, of course, some inflammation, some cellular infiltrate into the glomeruli. All types of cells, neutrophils and monocytes and lymphocytes will be seen. but it might not be very impressive in minimal change disease. But in other types, there will be more significant abnormalities. Immunofluorescence microscopy, that is a thing very important, because the main pathology in glomerulonephritis is the deposition of immune complexes on both sides of the basement membrane, on the endothelial sides and also on the epithelial sides. Now these immune complexes can be best detected by immunofluorescent techniques. These are certain stains which would create fluorescence if immune complexes are present. So I think this is very important. Then electron microscopy, which is mostly an investigative or a research tool, but in clinical settings it's usually not done. But if you do, you will see certain changes. I'm going to show you those changes. Now this is the under light microscope. This is one big structure, and this is actually glomerulus. You can see a lot of cellular infiltrates, not only here but also into the interstitium in the mesenterium. So there is a cellular infiltrate, and then this is the immunofluorescence. This green color indicates the presence of immune complexes. These are different glomeruli. This is one structure, and these are different glomeruli showing different patterns. Depending upon the subtype of post-streptococcal glomerulonephritis, you would have different patterns. Now in electron microscopy, you would see these deposits, these bumps on the epithelial sides. This is very characteristic of post-streptococcal glomerulonephritis. As I said, diagnosis of post-streptococcal glomerulonephritis is mostly clinical and based and supported by urine examination, and sometimes we do the imaging test also to see the kidneys, but mostly it is the urine and the blood test. The management principles, first of all, we manage them conservatively. First of all, we watch the natural course of the disease. Although the infection occurs 2 to 3 weeks before this glomerulonephritis occurs, and most of them, they would have already recovered from the infection, but it is usual practice to give a course of antibiotic which is effective against streptococci. It could be some penicillin, benzyl penicillin or amoxicillin or ampicillin, something like that. And other components of conservative management is fluid restriction, fluid regulation, urine output measurement, and restricted protein intake, because these patients, they do need protein, but protein can lead to creatinine and urea. So we give very limited quantity of proteins consisting of essential amino acids. Then we manage their fluid intake, we manage their urine output, and then we measure their electrolytes daily, measure their creatinine daily, and then we see when to intervene with hemodialysis if that is required. Immunosuppressive therapy is not needed in majority, but those patients who progress to advanced disease, their immunosuppressive therapy can definitely be considered. We can give steroids. We can give other immunosuppressive therapies like cyclophosphamide, azathioprine, and methotrexate. Other immunosuppressive therapies are given. And antihypertensive therapy is also recommended if patient develop hypertension. I think the best antihypertensive in this patient would be amlodipine with furosemide. RAS blockers, because they can sometimes increase creatinine. RAS blockers may not be very useful. Beta blockers are too mild. So the best is amlodipine, and amlodipine is very easy to manage also. So amlodipine with furosemide would be primary antihypertensive treatment in this patient. So we hope, actually we just hope that people will recover. Many do recover, may not recover completely. Usually those patients who recover, they also, I think there is some residual kidney damage, but they can actually clinically they recover. So complication, it could lead to chronic kidney disease. Sometimes despite immunosuppressive therapy, patient progresses to develop chronic kidney disease, and chronic kidney disease goes through various stages, and ultimately the patient may require dialysis or renal transplant. Then end-stage renal disease, I've already talked. Nephrotic syndrome, sometimes patient's kidney function may be reasonably preserved. The creatinine may not be that bad, but they have this frank edema. They have hypoproteinemia, they have frank proteinuria, they have hyperlipidemia, and they have generalized edema. This is called nephrotic syndrome, and this is usually managed conservatively with furosemide and also protein supplements. Prognosis, variable depending upon the type and severity. For example, if there is minimal change disease, the prognosis may be good, but if it is rapidly progressive, crescentic, proliferative nephropathy, then prognosis may not be very good. Importance of early diagnosis and management, of course, cannot be overemphasized. In any disease, if it is diagnosed early, it could lead to better outcome. So patients need to be educated, especially in the acute management. Families also play a role, nurses play a role. So they need to be educated on importance of compliance, because if you give advice about diet and fluid intake, and if the child does not comply with that, drinks too much water, takes too much salts, that would lead to pulmonary edema. So I think importance of compliance, and then diet and lifestyle modification. Even in chronic disease, we modify the diet in such a way that leads to minimum burden on kidneys, and monitoring signs and symptoms, especially the blood pressure and the lung condition, the pulmonary edema. So if there is any problem, we intervene with the medication. So conclusion, this is an acute post-streptococcal glomerulonephritis is a rare complication of common infection. Although it is a rare complication, but since the infection, the primary cause is common, so we still see patients in our country. In those societies where these common infections are less common, this post-streptococcal glomerulonephritis has become a rare disease. Natural course is variable, maybe reasonable recovery, almost to normal, or sometimes it progresses on to full-fledged nephrotic syndrome or renal failure. So I am not aware of any preventive treatment. If you use the pneumococcal vaccine, maybe that can prevent streptococcal infection, and that can also prevent these complications, but I'm not sure. So I think with that, I'd like to thank you for watching this video. This has been Professor Aziz Rehman from Medurstand-Understanding Medicine, and I really look forward to see you in my next video. Thank you.